say thank you very much for coming along, and we really look forward to your presentation.
Thank you so much, Ken. I'm delighted to be here today to talk to you about my research on ADHD. And I Ken gave such a good introduction. I don't need to do anything further. I just wanted to also say I'm on Twitter for those of you who are on Twitter and would like to follow me and the research that I do. So before I get started with my talk, I just wanted to have a quick note about language. We know that gender or gender identity and sex or biological sex are distinct concepts, but most research studies don't tend to, or the sorts of studies that I'm going to be talking to you about today, particularly genetic and epidemiological studies, examine sex differences. So I'll be talking about males and females mostly throughout my talk, but I will be using some of these terms interchangeably. And especially when I'm talking about general statements related to clinical practice or what we know about clinical practice or how parents and teachers perceive ADHD in children and young people or in adults, I'll sometimes be referring to gender. So just to kind of note that before I get started. So the outline of my talk is I'm going to give a very brief background on ADHD, and then I'm going to launch into 3 different key questions. And I'll talk about the research around those. So the first question is about what causes ADHD and whether the causes of ADHD actually differ in males and females. And this really is about focusing on understanding genetic factors. And that's what the research group I'm working with at Cardiff University that we're interested in particular. The second key question is what happens to females who have genetic factors that are linked to ADHD? Do they always develop ADHD or do they have other difficulties? And the third key question is, why is ADHD more likely to be missed and not diagnosed in girls and women compared to boys and men? So we all know ADHD is a very common neurodevelopmental condition. And in terms of how we diagnose it, ADHD is really an umbrella term for a couple of different subtypes. We've got the inattentive subtype, the hyperactive impulsive subtype, and then the combined subtype, which is characterized by difficulties in both domains. In order to get the diagnosis, the symptoms need to onset during childhood. So according to the diagnostic criteria, at least before the age of 12. So even in adults, the symptoms need to have been present during childhood. They also need to be pervasive, which means they need to be present across multiple settings, typically for children in the school and home environment, and they need to be associated with some level of impairment in terms of daily functioning. This is a very common condition in children, affecting about 1 in 20 children, or 5% globally. But what's really important and relevant to this talk is the fact that when we look at clinical studies, there are about 7 or 8 boys who are diagnosed for every girl who gets a diagnosis. However, when we then look at population studies or community samples, when we screen all children in a population to see who and who doesn't have ADHD, we see that the male to female ratio is a bit different. It's about 3 or 4 males for every female. Suggesting, and this difference between the clinical and community studies suggests that there's actually females in the population who have ADHD, but they're just not getting to clinics, they're not getting diagnosed. In general, when we look at the UK data, as well as in other countries, there is underdiagnosis of ADHD, both in males and females, but especially so in girls. This is just a quick graph from some data from a survey of children and young people in England from a few years ago. And you can see that it's split by boys and girls here, as well as by ages. And we can see that overall, boys have a prevalence of about 2.6%, which is less than what we see globally in England. And girls, it's only 0.6%. So we're really seeing a vast difference in terms of gender. But ADHD is not just a childhood condition. About 2 out of every 3 children who have ADHD continue to have difficulties as adults. And the prevalence of ADHD that's been estimated in adults is about 3%, which is still really quite a high prevalence. In order to get a diagnosis as an adult, you can have fewer symptoms than during childhood, but you still have to have had the difficulties present during childhood to get the diagnosis. Now, there is an ongoing debate in the scientific literature at the moment about whether there is such a thing as late onset ADHD without symptoms during childhood. And I will touch on this a little bit later in my slides. But what's very interesting for the moment is that when we look at studies of adults with ADHD, the male to female ratio is much closer to 1:1. Some studies show 2:1 or 3:1, but a lot of them actually show 1:1, suggesting that there's not this difference in prevalence in adults. ADHD not only does persist into adulthood, but it's also associated with lifelong adverse outcomes, including co-occurring neurodevelopmental conditions and learning difficulties, as well as associated mental health problems like anxiety, depression, substance misuse, self-harm, and others, and as well as other social and educational outcomes, things like unemployment, relationship problems, criminality, and premature mortality, even from a variety of causes. So this is a really important condition to study because it does impact on people throughout their lives. Going back to thinking about gender and ADHD, we know that the age at which girls are diagnosed with ADHD is later than in boys. Studies have estimated that boys are diagnosed at a median age of about 10 or 11, and girls are diagnosed at a median age of about 15. Now, this is a slightly complicated figure, but I'll talk you through it. So on the x-axis here, we've got age, and then we've got two y-axes with a variety of things being shown. This is data from a population study in Denmark, where they basically looked at what is the incidence of ADHD at various times throughout someone's life. And what they found is that cumulatively, overall, this dashed line here, by age 18, males have a much higher incidence of ADHD than girls, which is this dashed line here. So there's a big gap here. But when we look specifically over time, we see there's a peak very early on at sort of age 7 or 8 here in males, suggesting that the highest incidence of ADHD is in early childhood, whereas in females, the highest incidence of ADHD is kind of at age 17. So there's this delay in getting a diagnosis. Now, even when girls are diagnosed, and it is perhaps delayed, they're still even then less likely to be prescribed with ADHD medication compared to boys. And this is even after you account for the symptom severity. So even at the same degree of having difficulties, girls are less likely to be prescribed the treatment. We know that medication doesn't necessarily help everyone, it's not necessarily always advised, but it can improve a variety of outcomes, for example, educational and occupational outcomes, and it can reduce a variety of risks associated with mental health difficulties, accidents, and criminality. So the fact that we're seeing that there's on various levels this inequality in timely access to clinical care and treatment in girls is a cause for concern. And not just on an individual level, we also know that ADHD has a big impact on the economy. So these are some numbers from the UK. We can see that overall, various mental health difficulties cost the UK economy a huge amount per year. And the majority of these costs are associated with lost productivity, as well as informal carers who are supporting individuals with mental health difficulties. When we look at ADHD, a study that was published in 2013, so these numbers probably will have only gone up, focused on adolescents and the cost of health, education, and social care related to ADHD in adolescents. And it estimated this would be about £670 million a year. However, these numbers don't even take into account any potential costs that are associated with delayed diagnosis and treatment, both to, well, the NHS and the wider economy. So we can see that there are individual costs as well as economic costs to ADHD. So that was just the background. Now I'm going to move on to the key first question in terms of what causes ADHD and whether these causes are different in males and females. We know that ADHD runs in families. We've known this for a very, very long time. And I thought I'd just illustrate this with this really fantastic study from Sweden, which looked at over 1.6 million individuals. And what they did is they looked at the likelihood of having ADHD if someone has a relative who has ADHD. So they looked at monozygotic twins, dizygotic twins, so these are identical twins and non-identical twins, full siblings, half siblings, as well as cousins. And they found that if someone has an identical twin who shares 100% of their DNA, who has ADHD, their likelihood of having ADHD is 64 times higher than someone who doesn't have a relative with ADHD. And if they have a sibling, a non-identical sibling that they share 50% of their DNA with, whether they're dizygotic twins or just full siblings, their probability of having ADHD is 8 times greater than someone in the general population. And then you see sort of a drop-off here with decreasing relatedness and decreasing likelihood. But nonetheless, even having a half cousin who has ADHD does increase someone's probability of having ADHD themselves. So we see this sort of pattern of increased risk of ADHD with increasing relatedness to someone who has ADHD. But we also know that families don't just share genetics, they also share environmental factors. They live in the same house, they live in the same neighborhood, that kind of thing. So studies have tried to tease apart what's genetic and what's shared environment by looking at twins. Now, as I said, identical twins share 100% of DNA, and non-identical twins share 50% of their DNA, but they all live usually in the same house. So it's possible to statistically tease apart what's going on. And these kinds of studies of twins have estimated that the heritability of ADHD is about 70 to 80%, which means that the vast majority of likelihood of having ADHD is due to genetic factors. And they found that shared environmental factors are of limited importance, and it's actually additional non-shared factors that might contribute to the rest of the likelihood of having ADHD. These studies have tried to estimate whether there are any differences in males and females, and they found that the heritability is very similar in males and females, and they didn't find any evidence of quantitative or qualitative sex differences. So I thought I'd just think about for a second, why would we study genetics? Well, aside from the fact that we know that ADHD, as well as other neurodevelopmental conditions, are highly heritable, we do want to understand how and when these factors contribute, because this can help us to help individuals who are impacted. And what we want to study is things like the genetic architecture of conditions. And this just means that we want to understand the number of genetic variants, the types, the locations in the genome, the frequency of their occurrence, and the biological pathways and processes that they are affecting. We can also study the strength and context of these associations. We know that genetic factors are not deterministic. Very, very few genetic factors are for particular conditions in medicine. A lot of genetic factors act within the environmental context. So we want to understand what this context is. And we really want to work towards precision medicine, or tailoring various treatments and therapies, be they talking therapies or medications, for affected individuals to know which bits will work for who and why and when. And the idea behind this is to help to reduce any distress and impact of difficulties, and really just to improve people's quality of life. But we want to understand these genetic factors in order to achieve this. One of the main kinds of studies that we do to kind of understand the genetics are called Genomewide association studies. And these are studies where a group of people, for example, people with ADHD, are compared to another group of people who don't have ADHD. And we look at their DNA across the whole genome, across all their chromosomes. We look at individual genetic variants. Another way of studying groups of people is by looking at parents and their children. So you can look at the mother and the father, the biological mother and the father, and the child, and you can compare the child's DNA to what's in parents that isn't transmitted to the child, so the non-transmitted parental DNA. You can also just assess a whole population of people and ask what symptoms of ADHD they have and count up their symptoms, and look at a continuous trait of ADHD and look at the genetics there. When we do these studies called GWAS, we tend to look at about 5 to 10 million different genetic variants across the whole genome. And these genetic variants are called single nucleotide polymorphisms, or SNPs, and they're common. They have a common frequency, so everybody will have SNPs in their genome. But because there's so many of these variants we look at, we really need really large samples, tens of thousands, or ideally even hundreds of thousands of people, to be able to really understand robustly and statistically be able to look at associations. So in ADHD, we have done several of these studies. The first one was published in 2019, which was the first study to discover the first genetic factors associated with ADHD. And then the follow-up study was published earlier this year. What we have learned is that ADHD is very complex and polygenic. Polygenic just means there's many genes that are involved. There isn't a single gene or even a handful of genes, it's many different genes. So the first study, published in 2019, looked at over 20,000 people with ADHD and over 35,000 people without ADHD. And this is a plot of the results. It's called a Manhattan plot because it kind of has skyscrapers like in Manhattan. And what you can see is on the x-axis here on the bottom is the chromosomes ranging from 1 to 22. They didn't look at sex chromosomes in this analysis. And on the y-axis is a strength of association. So what is robustly associated with ADHD. And you can see these peaks. They're not just in one location, they're scattered throughout the genome. And these are the association signals. These are the genetic variants that are either increased frequency in people with ADHD compared to people without, or decreased frequency in people with ADHD compared to without. And there were 12 of these peaks. But earlier this year, a new study was published, which had even more people and detected even more genetic variants linked to ADHD. These genetic variants in themselves are important. Some of the genes that they are falling within make sense. One of those genes is DUSP6, which is a dopamine gene. It acts on dopamine neurotransmitters in the brain. And we know that ADHD medication impacts on dopamine. So in a way, it's not discovering anything new, but it could lead to understanding the mechanisms for the medication. But many of these other genetic variants are new and perhaps unexpected. But what we can say about them collectively is that they impact on biological processes that are relevant to the brain, to neurons, and particularly to dopaminergic neurons, which makes sense. The other thing we can tell about these studies is that genetic factors that have been discovered in these studies are linked to various other features in people. For example, difficulties with cognition, or what we call executive functions. And I'll also mention this a little bit later again. But we have a long way to go. Even though we have these enormous studies, we're beginning to identify genetic factors linked to ADHD. Actually, when we look at other behavioral and mental health or neurodevelopmental conditions, ADHD is lagging behind. People have looked at things like anxiety disorder, major depressive disorder, schizophrenia, bipolar disorder, and they've had bigger sample sizes and more genetic variants that have been discovered. So we have a long way to go to understand more about the genetics of ADHD. The other thing that is concerning is that most of the samples that have been included in these big international consortium analyses have tended to be of people of primarily European ancestry. And actually, we need to improve the diversity of these samples because that's ethically the right thing to do, but also because it will actually gain us additional knowledge. And we need to better understand the biological mechanisms. So future directions in this area are bigger and more diverse samples and functional translation to understand what the genetic variants are doing. What we can use these studies for is sort of secondary analyses. So using the discovery data sets from GWAS analyses, we can look in another sample and we can calculate on an individual level someone's genetic predisposition to ADHD or another condition. So we can count up for every single person in a population how many genetic variants they have that have been associated with ADHD, and we can weight them by their effect sizes and that kind of thing. And for every single person, assign them a score, which we call a polygenic score. And people with a low polygenic score are less likely to have they don't have such a high genetic predisposition to ADHD, whereas people with a higher score have a higher genetic predisposition to ADHD. This methodology only looks at common genetic factors, so it won't look at things like rare mutations in the genome. It's just the common SNPs that I mentioned. And it's specific to a condition of interest. So in our case here, we're talking about ADHD. So one thing that's really important to note is that everyone in the population can have a polygenic score and will have some genetic factors that are linked to ADHD. But what we want to know is whether the kind of having more genetic factors linked to ADHD is associated with particular outcomes in people. A couple of caveats though. These scores can't really be used clinically to predict what will happen to anyone at the moment because we need really bigger discovery samples to have more certainty about these scores. And the other thing I already mentioned is that they're ancestry specific and they don't really translate very well across ancestries because of the population frequency of genetic variants. But bearing that in mind, there have been a lot of studies that have looked at polygenic scores for ADHD and what they're associated with. We know that polygenic scores for diagnosed ADHD are associated with symptoms of ADHD in the general population. They're also associated with things like persistence of symptoms across time and things like subthreshold symptoms. So it's not just that polygenic scores for ADHD are associated with diagnosed ADHD, they're associated with many other definitions of ADHD. But they're associated with things beyond ADHD. They're associated with other childhood difficulties, be they anxiety or depression or conduct difficulties. Polygenic scores are associated with kind of a general factor of childhood mental health and neurodevelopmental difficulties. As I mentioned earlier, they're also associated, these polygenic scores are associated with cognitive difficulties, things like working memory problems, other executive functions. And interestingly, when we look at people who have ADHD, so these studies really have so far been like just in the population, but when we look at people who have a diagnosis of ADHD, a higher polygenic score is associated with more difficulties, things like co-occurring conduct problems, having irritability, very severe irritability, and substance misuse. One of the things we can learn from genetics is how best to define ADHD. Now we know that clinically in medicine, doctors use ADHD as a categorical diagnosis. You have it or you don't. But we know that in the population, people can have symptoms of ADHD that don't meet the diagnostic thresholds. So one question that we can ask is whether ADHD that is diagnosed categorically is qualitatively different from traits and behaviors in the population. Is there something special about having the diagnosis, or is it a continuum? Is it really a kind of the far end of a distribution of traits in the population? And the answer is, it is. It is the far end of a distribution of traits. We know from studies of twins that have compared identical and non-identical twins that mild and severe levels of symptoms, so high levels and low levels of symptoms, show similar genetic effects. They have similar heritability. We also know from GWAS studies that the genetic correlation between diagnosis and traits of ADHD is very high. It's really close to 1. So on the whole, we're seeing that there's these shared genetic risks between kind of low levels and high levels of ADHD symptoms. And whilst diagnosis is useful for clinical decisions, we can't give ADHD medication or talking therapies necessarily to every person because of, restrictions on funding and resources. But we do know that for research purposes and to all intents and purposes, and thinking about neurodiversity, ADHD is a dimension in the population, and this is supported by the genetics. So moving on to a different kind of genetic variation. I've been talking about kind of common variants that everyone in the population has these common variants, but we're also interested in studying more rare genetic variations. And one of these classes of variation are called copy number variants. And this is basically when someone has a duplication where there's a whole section of DNA that's sort of featuring twice or even 3 times, or a deletion where they have a missing bit of DNA on one of their chromosomes. Typically, we all have 2 copies of all our chromosomes, one inherited from our biological mother, one from a biological father, but it's possible to have fewer or more copies. And actually, really everyone has some CNVs, but it's the rare CNVs and the ones that are really large and affect more genes that are likely to disrupt core biological processes and have an impact on brain development. We've known for a long time that rare and large CNVs are associated with various congenital physical issues, things like heart problems, epilepsy, and cleft palate. But we also know they can have an impact on people's development of their brains. There are well-known genetic syndromes, like, for example, velocardiofacial syndrome, which is also known as 22q11.2 deletion syndrome. And that basically is a section of chromosome 22 is missing in some people, and they can have various syndromic features, including learning difficulties, sometimes ADHD, and other difficulties. So studies have begun to show that people with neurodevelopmental conditions like autism spectrum disorder, intellectual disability, and ADHD are more likely to have these large rare CNVs than individuals without these conditions. So they are relevant to ADHD. And in some work that we've done at Cardiff University, we found that CNVs that are specific to a child and not inherited from either parent, so they've kind of occurred de novo in the child, these CNVs are at a higher rate in people with ADHD than people without ADHD. So what have the genetic studies taught us about ADHD? Well, as I mentioned, everyone in the population will have some genetic factors linked to ADHD, but people with ADHD will have more of these genetic factors than the average person, and everyone with ADHD will have a different mix of specific genetic factors. The types and amounts of genetic factors, what I kind of referred to as the genetic architecture previously, can impact on types of difficulties someone has, co-occurring mental health problems, the degree of difficulties, and whether these persist over time. So we can learn quite a lot from the genetics, really. One of the things that I've been very interested in my own research is looking at males and females. Can we determine, are there any sex differences in genetic factors? Is ADHD the same condition biologically? And in this study, we looked at nearly 5,000 females and nearly 14,000 males who have a diagnosis of ADHD, and we compared the genetic factors in these individuals. And we found that it was largely the same common genetic factors linked to ADHD in males and females. Correlation was very close to 1, suggesting that at least for common genetic factors, it is biologically the same condition. We also wanted to know whether there's maybe a quantitative difference. Do girls, for example, require a higher genetic loading to develop ADHD, given that there's fewer girls who are getting diagnosed? So we compared the DNA in males and females to see whether there was a quantitative difference in looking at polygenic scores, likelihood of having a rare copy number variant. We didn't find any differences when we looked at a variety of clinical and population samples to define people with ADHD. However, when we looked at a population and looked at people's relatives, we focused on a subsample of the Swedish population of about 78,000 people with a diagnosis of ADHD. We found that the siblings of females who had ADHD, so basically having a sister with ADHD, meant someone was at a higher probability of having ADHD than having a brother with ADHD. So there was a little bit of a quantitative difference, but this could be explained potentially by other factors to do with how diagnoses are made, not necessarily the genetics themselves. So overall, we found limited evidence of quantitative or qualitative differences in genetic factors in people with ADHD. So to answer the first question, what causes ADHD and are these causes different in males and females? Well, ADHD is clearly a neurodevelopmental and brain-based condition, highly heritable. It's largely caused by variation in genetic factors. but it's complex. There's not a gene for ADHD. There's tens of thousands of different genetic factors of different frequencies across the genome, which play a role. I haven't really touched on this, but we know that there will be some non-genetic factors. It's not 100% genetics. Some of these are things like preterm birth or things that happen during pregnancy. But actually, a lot of non-genetic factors that people have studied have ended up being at least partially influenced by genetics. So we don't really know what environmental factors definitely cause ADHD that isn't already linked to kind of the genetics. And looking at sex differences, we find limited evidence that there are any of these differences in genetic factors. But just to bear in mind that this is using our established diagnostic criteria and our symptom definitions, we see that ADHD appears to be genetically similar in males and females. Moving on to the second question of the talk. So what happens to females who have genetic factors linked to ADHD? I mean, males and females will be inheriting the same kinds of genetic factors. Why are females not getting diagnosed as much as males? One thing that we have learned from genetic studies is that the genetic factors underlying ADHD overlap with those related to other conditions like anxiety or depression. So this figure here shows kind of a network of genetic correlations across different conditions. For example, we see that bipolar disorder and schizophrenia show a very strong genetic correlation. And these two conditions do run in families. We also see that ADHD and autism spectrum disorder have a genetic correlation of about 0.37, which is a moderate genetic correlation. There's some shared genetic factors. And ADHD seems to share quite a lot of genetic factors with major depressive disorder. And this plot doesn't show it, but also the same is true of anxiety. Interestingly, in some work we've done, we found that there aren't really sex differences in the strength of shared genetic effects. So the genetic correlation between ADHD and depression in males is similar to in females. But one possibility is that the same genetic factors can actually manifest in a different condition in different people. So one of the questions that I wanted to address in my research in the last sort of 5-10 years was whether females who have genetic factors that are linked to ADHD might be getting diagnosed with another condition, for example, anxiety or depression. So I set out to study this. And I used a variety of different samples to get at this issue. So I'll talk you through the details. First, looking at people, children, young people in the general population. We looked at data from Sweden, and we included over 13,000 children who were part of the child and adolescent twin study in Sweden, who'd been diagnosed with anxiety and depression using the ICD-10 criteria, according to the Swedish National Patient Register. And we looked at these individuals and we compared boys and girls with these conditions in terms of their ADHD genetic factors. And girls had higher polygenic scores linked to ADHD compared to boys. So even though they had higher polygenic scores for ADHD, they had anxiety and depression, were more likely to have anxiety and depression. They also were more likely to have a large rare copy number variant, which we know these are linked to ADHD as well. So it looked like some of the girls were having more genetic factors linked to ADHD, but actually ending up with anxiety and depression. But this was specific to how we defined anxiety and depression. When we looked at everyone and assessed, we had questionnaire data from parents and self-reported questionnaires about symptoms of anxiety and depression. So we screened everyone and we looked at their symptoms. When we define anxiety and depression this way, we didn't see any sex differences. So it was something to do with the diagnoses in the actual healthcare records. And we also looked in a second sample, the ALSPAC study or the Children in the 90s study in Bristol. And we found that when you screen everyone, you don't see a sex difference. So this suggests that there may be some kind of role of diagnostic biases where girls who have ADHD genetic factors might be getting diagnosed with anxiety and depression. So I went on to look at this in another sample. This is a sample called the Longitudinal Study of Genetic Influences on Cognition or Logic at Massachusetts General Hospital in Boston in the States. And we looked at a clinical sample of children, over 1,000 children, who'd undergone a lot of very thorough screening. They'd done cognitive assessments, their parents had done interviews and questionnaires, and there was linkage with patient notes. We had loads of information. So it was a very thoroughly screened sample, and we identified anyone who had anxiety and depression. Again, we saw no sex differences in polygenic scores for ADHD when we used this very thoroughly screened sample. So there were no real diagnostic biases within this sample. And this is consistent with the previous population studies. So next we wanted to look at adults. Do we see something in adults? Another study that had been published in the meantime using the UK Biobank data, which is a large population sample of primarily middle-aged older adults. And they found that depression in women was associated with rare neuropsychiatric CNVs, these rare genetic variants that we know are linked to ADHD. So that seemed to suggest that maybe in adults you see similar things. So we looked at data from the Swedish patient register. We looked at over 150,000 sibling pairs, and we found that females who had a diagnosis of anxiety were more likely than males who had a diagnosis of anxiety to have a brother with ADHD. There was a little bit of family history that was linked to anxiety in females compared to anxiety in males. But when we looked at depression, bipolar disorder, and eating disorders, we didn't see this association. And we also didn't see the association about having a sister with ADHD. So it was very specific, and it wasn't a very, very strong result. So we looked at other samples. We looked at a cohort from Cardiff University, the National Center for Mental Health cohort, of adults who've self-reported that they have a doctor's diagnosis of anxiety and depression. There were over 1,000 people in this sample. And we found no evidence of higher ADHD polygenic scores in females than in males in this group. And finally, we looked at data from the Psychiatric Genomics Consortium, looking at individuals who've been clinically diagnosed with major depressive disorder. This was a very big sample, again, about 13,000 people. And we found that in this group, women who had an early onset of depression before they were in their 20s, had higher polygenic scores for ADHD than men who had early onset depression. But the effect was quite small. So we're seeing kind of mixed evidence in later life and when diagnostic biases are minimized. So kind of just to wrap that section up, what happens to females who have genetic factors linked to ADHD? Well, collectively, these studies suggest there's some evidence that in individuals who've been diagnosed with anxiety and depression, females may have more genetic factors linked to ADHD. So it could be that the ADHD genetic factors are actually resulting in anxiety and depression. But it seems to be only when we look at real-world diagnoses based on kind of clinical practice. And we don't see these sex differences when people are carefully screened. And it seems to be more in younger people, less so in adults. So what's going on? Well, it seems like maybe we know ADHD can be missed in females. Maybe it's more likely to be missed if they have anxiety and depression, but then eventually diagnosed later in life. So that's why the results change when we look at adults. So moving on to the final question of the talk. So if it's not necessarily the genetics, why is ADHD more likely to be missed and not diagnosed in girls and women? And I've got 7 possible explanations here, which are not mutually exclusive. They may be part of the picture, and they're really looking at diagnostic practices and social factors. And I'll go through each one of these in turn. So our criteria that we use to diagnose ADHD are based on studies from the 80s and the 90s, which were mostly of males with ADHD. The diagnostic criteria themselves are based on males and the male presentation of ADHD. And it's been suggested by a number of people that maybe the symptoms are presenting differently in females and they're just not well captured by the diagnostic criteria. Some suggestions have been that maybe in females, symptoms are more kind of internal and less visible to others, things like daydreaming or having restless thoughts or emotional dysregulation difficulties. The criteria we have are very task-oriented. They're about getting schoolwork done and focusing on things, whereas maybe in girls, they're more social relationship-oriented difficulties. Some of the kind of suggested symptoms that might be happening in girls are things like verbal impulsivity, being loud and chatty, whispering or talking to peers in class, passing notes during class, changing friends impulsively. Much more social things, but things that are difficulties that may be experienced by people with ADHD. And these symptoms, whilst not part of the diagnostic criteria, are associated with impairment. So it's possible that our diagnostic manuals, future versions of them, could benefit from including more sex-specific examples, not just the male presentation. Another possibility is that there are actually sex differences in the existing DSM symptoms. So we know we have our 18 symptoms, but maybe some of the symptoms are more or less common in males and females. And in particular, it's been suggested that the inattentive symptoms are more common in females. And these, because they're less disruptive to other people, they might be more easily missed. So just to show you some data on this, I mentioned there's these 3 subtypes, the inattentive, hyperactive, impulsive, and combined subtypes. in that clinical sample from Boston that I mentioned, we had 850 people who had a diagnosis of ADHD, and females were 40% of females with ADHD had an inattentive subtype diagnosis, but only 30% of males. Whereas for combined type, it was the opposite way around. Males were more likely to have combined type compared to females. Other studies have shown similar things, inattentive type being more common in girls than boys in this study here. So there might be a difference in the subtype of ADHD by sex, but people have looked at the levels of symptoms, kind of the severity or the number of symptoms of ADHD, and have done like a systematic review of the literature of all the studies that have looked at this, and have found that when parents are reporting on symptoms in boys and girls, there are no overall differences. When teachers are reporting on the symptoms, it seems that they're rating boys as having more symptoms. So there's a little bit of inconsistency in like clinical subtype versus the actual kind of symptom levels. So it's not entirely clear that females have more inattentive symptoms as such, but maybe they're being more likely to be diagnosed with this subtype. Another possibility for why we're seeing this sex difference in prevalence of ADHD is that females require a higher diagnostic threshold to get the diagnosis. So studies have looked at what the symptoms look like in girls and have found that high levels of ADHD symptoms are just less likely to be diagnosed in girls unless they have particularly prominent hyperactive impulsive difficulties, not just inattentive symptoms, or conduct problems, which are very disruptive, or additional things like emotional or peer problems. So having these extra difficulties on top of their ADHD symptoms makes them more likely to get the diagnosis. Similarly, girls are more likely to receive medication for their ADHD if they have additional behavioral and emotional problems. And if they don't have these problems, they might be less likely to get the medication. So it seems that the referral, diagnosis, and treatment of ADHD in girls may be driven by having additional difficulties, particularly ones that are less typical in girls, like conduct issues. And it has been suggested that perhaps we should be using sex-specific symptom thresholds. So whether we should be sort of diagnosing ADHD differently in males and females and having a different threshold of what number of symptoms is enough. And one study looked at whether you end up with sort of a different number of people with ADHD depending on if you shift that threshold. And they found that there is a small but important group of girls that are considered sub-threshold. So they have elevated ADHD symptoms and they have associated impairment, but they don't quite meet our current diagnostic criteria, but they are really, having more difficulties and more symptoms than males. And you don't see these sort of sub-threshold group in boys. Another possibility is that there are gendered expectations of adults who, would be the ones to refer children for ADHD diagnosis. Studies have looked into this by presenting parents and teachers descriptions of children with difficulties relating to ADHD, and they've done something really clever where they've just given the exact same description, but with just the name and the pronouns changed. And they found that just that small change can influence whether a parent or a teacher is likely to recommend referral for ADHD, learning assistance, counseling and treatment, and they're less likely to make these recommendations for girls than boys, even though they have the same difficulties. There's also been evidence to suggest that there are gender differences in the descriptions and perceptions of what ADHD looks like, according to teachers. For example, teachers tend to highlight more verbal symptoms in girls and more motor activity symptoms like running around and fidgeting in boys. Which, it's important that we're seeing these differences, but I just want to also highlight that not all studies have consistently found these difficulties. It could be that in certain places or in certain schools or in certain contexts, you see these differences and otherwise you don't. Some studies have found that in children who have academic problems, teachers actually end up rating girls as having more difficulties than boys. And some studies have just found no gender differences in teacher recognition, but they have found differences in recognition of different subtypes, with inattentive subtype being less likely to be identified than combined type. Another possibility is that there is overshadowing of ADHD based on other co-occurring difficulties. We know that mental health difficulties are very common in people with ADHD, things like anxiety, self-harm, depression. So if these conditions are recognized clinically and diagnosed, perhaps ADHD is missed sometimes. In the general population, boys are more likely to have conduct difficulties, girls are more likely to have anxiety, mood, and eating disorders. And we see the same thing in people with ADHD. One study by some of my colleagues at Cardiff University looked at adult women who had recurrent depression, so recurrent major depressive disorder over time, and they assessed ADHD in this group. And they found that quite a substantial part of the sample, 12.8%, had elevated symptoms of ADHD, but had never had a diagnosis. So these potentially are individuals who've had that diagnostic overshadowing happen. As I mentioned in the slides on genetics, we found that in children with a diagnosis of anxiety and depression, girls had a higher polygenic score for ADHD and were more likely to have larger SCMBs than boys. That could be because of diagnostic overshadowing again. So there's a possible role where there's diagnostic biases, where girls who are at genetic predisposition to ADHD might be getting diagnosed with anxiety and depression. They might have ADHD underlying, but maybe it's overshadowed by these other conditions. Another possibility is that the symptoms progress differently in terms of the development, and that there's later onset of difficulties in girls. I mentioned early on that there's a growing debate as to whether ADHD is always a childhood onset condition. And there have been some studies published suggesting that actually, for some people, ADHD symptoms can first emerge in adulthood without any kind of obvious ADHD prior to adulthood. Other studies have questioned this and suggested that, well, actually, maybe there are like subthreshold symptoms of ADHD or other difficulties in childhood, and the ADHD kind of becomes more pronounced later in life. What they have found is that this late onset ADHD is more common in females than males. And the late onset and childhood onset ADHD seem kind of similar. They're associated with similar genetic factors. They're associated with cognitive difficulties, but there are some differences. Individuals with late onset ADHD tend to have higher IQ, have higher reading ability, and higher socioeconomic status based on things like family income and maternal education. So I guess the possibility is that problems are starting later, but maybe another possibility is that they're being masked or missed earlier on and actually only just getting recognized in adulthood. Which brings me to the last point, which is perhaps there are differences in people compensating or masking for their difficulties. We know that young neurodivergent people, as well as older neurodivergent people, do compensate for difficulties that they have. They hide them, they mask them, they try to fit in amongst their peers. And one question is whether girls and women are more likely to be doing this. Studies of autism spectrum disorder or autism have found that compensatory strategies are often used to modify social behavior, particularly in individuals who have better cognitive abilities. And some studies have found that women are more likely to do this, whereas other studies have found that unclear gender differences in this. In ADHD, we know that girls are more likely to have pro-social behaviors. They're more likely to be liked by adults and peers. And these pro-social behaviors could be masking difficulties and reducing concerns from adults. But really, this is a very new area, and we need to work more and do more research to better understand this in the context of ADHD as to whether there are gender differences in this area. So I've gone through these 7 possible explanations for why we're missing ADHD in girls and young women. And really, there isn't a single explanation. There are many different factors. They all kind of work together. They're all part of the picture. But we also do need more research on some of these to really kind of get at what exactly is going on. So I'm reaching the end of my talk. So my kind of concluding few slides. ADHD diagnosis can be delayed or even missed in girls. And I believe strongly that there's inequality in access to clinical care and treatment, and this is an issue for concern. I've gone through various possible explanations for why we're seeing this. In terms of the biology or the genetics, at least, we don't see sort of strong evidence of sex differences given the samples we have using our established criteria and symptom definitions. There's some evidence suggesting that females who have genetic factors linked to ADHD might actually be getting diagnosed with anxiety and depression, but this could be some kind of diagnostic overshadowing. In terms of our diagnostic practices in general, there's a variety of issues that might be happening. Our criteria are geared towards male presentation. Females might need a higher threshold to develop to be diagnosed. They need to have additional difficulties to be diagnosed. And there's potentially this overshadowing from other conditions. There are also various social reasons. There are sex differences in presentation potentially, perhaps inadequate recognition from parents and teachers in some areas, potentially compensation and masking, as well as later onset of symptoms. There's a variety of things going on. And there are many healthcare, education, and policy implications, but mostly we need more resources for earlier, timely identification of ADHD in young girls. Assessment waiting lists are extremely long, and we need better, earlier interventions. We also need to raise awareness for various people, including teachers, other educational staff, GPs, on what to look out for. And we need more research to better understand the sex differences in presentation and factors and consequences related to missed and delayed diagnosis. So I'd just like to mention that I've got a 5-year grant from Health and Care Research Wales to study some of these issues. So, watch this space. Hopefully in a few years' time, we'll have some results to share about what we find. But we're hoping to improve knowledge, awareness, and timely diagnosis of ADHD, particularly in young women, but also, in people of all genders, to help improve people's health and social outcomes. And as part of that, we recently launched a qualitative study where we're actually talking to people with lived experiences of ADHD, as well as other experts like parents and carers of girls with ADHD, healthcare and educational professionals. And we're looking to find out about the experiences of girls growing up with ADHD and people supporting girls, to find out what the symptoms look like, how they're manifesting. And we're planning on developing a new gender-inclusive assessment tool for primary school children. You can see the study page here, and I'm also on Twitter. The study, I'm afraid, is recruitment in the UK only. And we've actually had a huge amount of interest, and particularly from young women diagnosed with ADHD, but also from parents and carers. So we're currently mostly just recruiting professionals, and we've started our interviews and focus groups already. So I'm very excited to look at the data soon. And I'd just like to acknowledge the team of people who are working with me on this project, including the ADHD Foundation Neurodiversity Charity, as well as the National Center for Mental Health, who are supporting us with a youth advisory group of young people with lived experiences of ADHD and other neurodivergent conditions who are involved in the study. And there's a variety of individuals across the UK and in Sweden who are involved. And I'd just like to acknowledge all my funders and collaborators. And that's the end of my slides. So thank you very much for your attention. I'm happy to take questions. And there are a lot of questions.
Oh, no, there's a lot. It's only going to go up. Someone says, this one, Amanda Gay just came here. Thank you. That was mind blowing. So thank you very much for that. And just there was a couple of questions just towards the end. People saying, just to let you know, we are recording it. It just takes us a couple of days to edit it and get it back out to you. So we will be sending the recording. So if you haven't got everything this evening, you will have an opportunity to watch it back. So at this stage now, we can have a look at some of the questions. There's a couple of questions just on the same thing, and I'll just jump in first before Terry and Tricia come back in with some questions. And this one came in from Claire, and I think it's around the social experience. And what she's saying is the experience of anxiety and depression due to the genetic brain-based reasons, or the challenge of being neurodiverse in a neurotypical world.
The answer is yes to both, I think. It is a great question, actually, and we can't necessarily distinguish on an individual basis, but on a population basis, it's a bit of both. We know that conditions like anxiety and depression, they're not as strongly heritable as neurodevelopmental conditions like ADHD and autism. Nonetheless, they do run in families, and they are to some degree influenced by genetic factors. But clearly, having a neurodevelopmental condition and being, bullied or stigmatized by other people in the environment can lead to anxiety and depression. So it is a bit of both, really.
Okay. Is it too soon to go to Terry, or will I take another one?
No, it's fine. I'm ready.
Perfect.
So Tammy wants to know, why is it that so many women are being diagnosed in perimenopause and menopause? What role do hormone influence play in ADHD?
This is a really good question that seems to come up a lot. And I'm really sorry to say that I do not know the science on that myself. And it is something that I would be interested to find out more about, but it's not something that I've studied myself. I think it's clear from kind of, anecdotal evidence that women with ADHD do experience variation in their symptoms according to their menstrual cycles. And like you say, there are these instances where people are getting diagnosed in that kind of life stage. I don't know exactly what's going on there. I think it is an important thing to study. I do know that there's actually ongoing research on those topics. So I guess, again, watch this space, and I will try to brush up on the literature, because I do keep getting asked this question, and I'm afraid I don't really know this area myself.
Thank you.
Well, again, thanks for that. And does Tricia have the next question?
So Jenna says, I thought that the subtypes of ADHD no longer was a thinking, that an individual's age and symptoms change due to masking and life stressors.
The subtypes question is really interesting. And yes, so it is the case that someone might kind of meet the criteria for a particular subtype at one point in their life and then go on and meet the criteria for a different subtype. They're not stable. They definitely do change around. So when we kind of present anything about subtypes, it's very much a snapshot at that moment in time rather than like a diagnosis someone gets for life. And they are fluid. I guess the other thing is that, you know, you can meet the inattentive subtype by only just missing one item on the hyperactive impulsive bit or something like that. But, you know, people still do use them in clinical practice. I know that also people sometimes find the identity of ADD or attention deficit disorder kind of is something that speaks to them. So they are kind of terms that are used. I don't feel like I captured the second part of that question though. Sorry, I didn't. I think there were like two bits to the question.
So just did the symptoms change due to masking or life stressors?
Oh, did you masking or life stressors? Yeah, I mean, I think the symptoms will be influenced by a variety of contextual factors, and for sure that, you know, it's not just natural kind of development. There will be influences externally that will influence how these symptoms present in particular contexts, for sure.
Okay. Just before we go to the next, I'll take the next question, then we go to Terry, but Joe Curran has just put in there, absolutely brilliant, Joanna. Thank you very much. I'm amazed at the work you and your team have carried out. And there's lots of other comments along the same lines. I thought this was a great question. It's a very simple question. I know you may not, this is more of a clinical than a research question, but this comes in from Em, and I think, you know, everybody with ADHD will be looking to get the answer to this in the next few years. How can we get our personal DAA assessed? I'm so interested in this.
So DAA assessment, is that disability?
DNA, sorry, excuse me.
Oh, I see, sorry, DNA. I mean, there are these like personal genomics companies that can do that. But I guess I'll stress it is very complicated. And these personal genomics companies don't necessarily explain quite how complicated it is. So for some medical conditions, like certain types of cancer, for example, it's not quite so complicated. So they can say, oh, your risk is this or that or the other, and it can be kind of easily-ish interpreted. For ADHD, this is such a complex condition that these scores that I've talked about, they're kind of useful on a population level. They're not necessarily useful on an individual level at the moment. This may change with more kind of advances and bigger data sets that we can use to calculate these scores. But right now, I think the only kind of traction of the genetic testing is where someone, and this is very rare, where someone does have one of these copy number variants. And that's, you know, the like less than 1% of people in the population have one of these large copy number variants. So it's those kind of syndromic genetic conditions can be informative. There are whole communities around specific genetic syndromes that people benefit from. But on the kind of larger scale of DNA testing, it's a little bit soon to really get personal benefit from it. It's more of a kind of academic issue for now, but that will, I mean, we've had advances so rapidly in the last 10 years that is likely to change in future.
Okay. Just a question just before it goes, I'll answer this one. So it's from Angela. Is there an ADHD support group for parents that I can join in Ireland? Yes, Angela, there is. If you go to adhdireland.ie, have a look in our events section, you'll see loads of them. Terry maybe will tell you more about those. Well, we do them for parents, we do them for teens, we do for parents of 18 to 24-year-olds. We got loads of them, and we've got parenting courses as well. So forgive the ad break, but over to Terry.
The next question. So it's from Belinda. So, hi, Joanna. I'd love to hear your thoughts on the connection between DAO, which is diamine oxidase, an enzyme that helps metabolize histamine deficiency, and ADHD. Thank you. Any idea?
Completely drawing a blank. I'm afraid I've never heard of this enzyme.
Okay.
The research I do is kind of epidemiological rather than the biology of specific proteins. So I'm afraid I'm not the right person to answer that one. Sorry.
Forgive me, I saw the question there earlier and I was looking on Google myself during your talk, so I'm not qualified either. But from looking briefly, there does seem to be a connection between DOA and other conditions like fibromyalgia, which tend to be more consistent in women of middle age with ADHD. So there may be a connection there, but as I say, I'm not a researcher by any stretch of the imagination, which is, I thought the question may be reasonable. Maybe go to Tricia for the next one.
Have any studies compared ADHD in females and males in single-sex schools versus mixed schools?
So is that, I guess, a question about differences in prevalence? I haven't seen anything on this. I mean, I guess there might be a difference in recognition, not necessarily the, whether people have it or not in the context of different kinds of schools, but the recognition might differ. So, I mean, I've definitely heard of situations where, like, a child in a particular neighborhood gets a diagnosis of autism, and then like several other children on the same street get diagnosed with autism because suddenly people become aware of it and realize, oh, that child's similar to my child or something like that. So I guess that could happen in the context of single-sex schools, but I mean, I'm just speculating at this point. I'm afraid I can't be an expert on everything.
No, again, I was doing a webinar with UCD this afternoon, and we had someone talking about LEANS, which is a schools program. And certainly from her research, and she was saying in terms of anybody else doing research, is do one thing well. You can't answer every question. So I very much accept what you've been doing in terms of your research. And, certainly you have done that one thing well. You may not know the answer to this one either, but it comes in from Cot Verling. Any ideas and stats on ADHD rates in sport? I've heard a statistic lots of times that, gold medal winners for the Olympics over-index for ADHD, but I don't know any verification of it.
Yeah, I don't know the stats on that, I'm afraid. But again, I feel like anecdotally it does come up. You get kind of high-profile people who disclose widely that they have ADHD, and that's good. That sort of helps with sort of anti-stigma and things like that. But I don't know if it's more common in particular sports or in particular domains. I guess people sometimes find a niche where they thrive, and that can be either a sports niche or an arts niche or any other kind of niche. So I imagine that there will definitely be representation, but I don't know the numbers.
Well, again, just Caught put into the chat there, right? She's read rates of they were high in elite sports. And again, I would have heard that anecdotally ourselves as well. And I think it's probably true. And you can probably see that, the fact around the hyperactivity. And if you had a hyper focus on top of that, but certainly you would be good at that. So maybe go back to Terry for the next question.
Sure, it's from Michelle. So during your research, did you find links between people who have dyslexia also have ADHD?
Not in my own research, but yes, definitely in the literature. There is evidence from things like twin studies looking at genetic correlations across different neurodevelopmental conditions, including ADHD, autism, tic disorders, learning difficulties, dyslexia, specific other learning difficulties. There are definitely kind of shared genetics underlying all of these neurodevelopmental conditions to some degree. And I think this is beginning to be backed up by studies of DNA, not just studies of twins. So there are kind of like shared biological bases to these conditions, but there all obviously also will be differences. They're only kind of partially overlapping genetic factors.
Cool. Thank you very much. Just a few more questions to go. We'll try and try and get as many, maybe up to around 8:15 to 8:30, and we can wrap up then. So if anybody does have any questions, if you want them asked, now is a good time to pop them in there. And maybe go to Tricia for the next one.
Sarah wants to, would medication for ADHD help with the depression experience as well, or should they be treated separately?
There is some evidence, I believe, suggesting that the medication for ADHD can potentially help a little bit, but I think to a large extent, if someone has co-occurring difficulties, they need to be supported with each of those difficulties and not just assume that one is definitely going to kind of, completely sort out one type of treatment or medication or talking therapy is going to help with everything at once. So individuals who have more complex needs, have additional things on top of having ADHD could benefit from additional things depending on what that is and what their healthcare supports. So I would probably say that it's good to get the additional support.
Okay, thanks. Just a couple of questions then, and interesting one from Tammy. Any studies on the prevalence of ADHD in eldest children compared to younger siblings?
This isn't a difficult area to study because of something that we call in the scientific literature stoppage effects, where, you know, sometimes people will stop having children once they have enough children, or if you know, like there's a huge variety of factors of why people have one or more, or, you know, children, and those kinds of decisions. So it's actually kind of a challenging thing to study. And I know I'm going to make a different point that sort of doesn't quite address that issue, but what's really interesting is there's very robust evidence to show that in the context of a classroom, the youngest children in the class are much more likely to have ADHD than the oldest children in the class. And actually this sort of kind of school age in school year type effect is very, very, very strong. But it's just a little bit more challenging to study in the context of individual families because of a variety of factors that influence this, that kind of like, I guess, muddy the waters a bit. So it's hard to say what's going on exactly.
Then just an earlier question would have come in from Nicole, was around the non-consensual testing for genetics in terms of research. Any view? I presume that doesn't happen anymore.
I mean, non-consensual testing should not happen. The sorts of studies that I've been outlining today, they're all ethically approved, and you cannot take there are, you know, there's the Human Tissue Act, there's GDPR, there's all sorts of protections where you know, an adult who is responsible for a young person has to consent, and the young person has to provide assent. You know, you can't provide consent until you're 18 legally, but you can provide assent. And so certainly in the studies where I've been involved, both the adult has consented and the young person has assented to provide the samples. And that shouldn't happen otherwise.
Okay, no, I just wanted to clear that one up. Maybe just go to then Terry for the next question.
Okay, so are there any links between ADHD and schizophrenia?
Yes, both in terms of the kind of symptomatology, but also in terms of the genetics. So unfortunately, ADHD does have a sort of increased risk for a variety of mental health outcomes, including severe mental illness like psychotic symptoms and very severe depression and suicide and these things. And obviously, you know, people with ADHD who are experiencing these things need the additional support, definitely. But it is the case that these things run in families. So someone who has a family history of schizophrenia is at increased likelihood of having ADHD and vice versa. And we do also see this in the genetic studies, the genetic correlations. I don't think they're exceptionally high. I think it's something like around, you know, 0.1, 0.2, but there is nonetheless a genetic correlation that suggests that there's some shared biology between severe mental illness like schizophrenia, bipolar disorder, and ADHD. It's not deterministic. It's very, yeah, it depends on the specific individuals. On a population level, we see these associations.
Cool, thanks for that. I say we'll keep going just for a few minutes because there's still loads of questions to get through. And we go to Tricia for the next question.
Fiona wants to know, is it often hormone related that girls get diagnosed in their teens? Can hormones changing bring on the symptoms more?
I mean, again, I guess this is an area I'm not really sure about, but I suppose, you know, puberty and these kinds of changes often coincide with moving from primary to secondary school. And when a child moves to secondary school, you know, there's a lot of changes that happen. There's a lot of kind of additional demands. They need to become more responsible. The kind of support they get for, you know, packing their school bag and things like that changes and maybe is lessened. So there's kind of a lot of things that are happening at that same time period, which would make it a little bit hard to say, you know, is it if there is a causal association, or if it's more that there are a number of things going on that are kind of co-occurring.
Okay, can I maybe ask you Matt's question then, based on the research? It says here from an anonymous attendee, if a mother and son are both diagnosed with ADHD, what's the probability of other children having it?
I mean, I don't know like a precise statistical answer to that, but I guess having, so in that situation, you know, another child would be 50% related to their sibling and 50% related to their mother. So according to the the population data that we have, that would suggest that there's at least an 8-fold increased likelihood over the general population. But I don't know if necessarily having multiple family members changes that number. I don't think it necessarily would. So I would say it's sort of the ballpark of 8 times more likely than someone in the population who doesn't have any siblings or parents with ADHD, roughly like that, yeah.
Then just one of the statistics that I've found confusing myself, and I may be wrong at this, which is always possible, that if a child has ADHD, there's a 25% probability that one of the parents would have ADHD. I would assume it was 50%.
I mean, it's not quite that straightforward because, like I say, these things are complex. So, we all have some genetic variants linked to ADHD, and they're not deterministic, right? So it's kind of about having the sort of buildup of those numbers. And we know from the autism literature that there's a thing that they talk about, which is called the broader autism phenotype, which is basically when a family member doesn't meet the diagnostic criteria for autism, but has symptoms, say subthreshold symptoms or traits or behaviors linked to autism. And I think that's very much the case in ADHD as well. So, someone might have a diagnosis of ADHD, but they might have a relative who has traits of ADHD that aren't diagnostic level, clinical level traits. They maybe aren't causing them the sort of impairment in their daily life, but they are kind of natural variation in their behavior. And this is kind of where neurodiversity comes in, right? These are conditions that are just common in the population, and the symptoms aren't something completely different. They're qualitatively similar in people who don't have ADHD. It's just about the number of symptoms, the number of difficulties, the context in which they present, and whether they cause people difficulties in some part of their lives.
Okay, thanks for that. And just let everybody know, we'd probably be about 10 minutes and we'll be wrapping up then. So maybe go to Terry for the next question.
Okay, so from an anonymous attendee, do you have a view on the theory that both ADHD and autism can be missed in girls and many boys, in brackets, because the individuals are both ADHD and autistic and the traits compensate and mask each other?
Oh, that is a really, really fascinating question. I love it. So I did my PhD on ADHD and autism and the overlap. And what we found is that people who have both types of difficulties often have kind of more complex difficulties because it's sort of like they're additive. So having the ADHD and the autism can cause, difficulties in multiple domains and cause lots of difficulties. But those are the people that we had in our studies. So it could be that there are people who have ADHD that, they have some difficulties, but then the autism kind of compensates for some of those and vice versa. And those individuals probably wouldn't come up in our studies. They wouldn't come up to clinical recognition. They wouldn't be presenting as ticking the boxes on the questionnaire that would indicate those problems. So I feel like the best way to study that would be to, do some kind of sampling of maybe the relatives of people who have diagnoses and see, are they doing well, and why are they doing well? Are they experiencing this sort of positive impact of converging symptoms? I mean, I love this question. This is fascinating. I feel like I want to study this now. It's a good question.
Cool.
Thank you. And go to Tricia for the next question.
Is there any study into women with ADHD parenting children with ADHD? Because such a genetic condition with emotional regulation issues and impulsivity, the impact is compounded generationally.
There are these kind of cross-generational studies, and yes, I mean it's sort of, there's the familial genetic angle, but there's also the kind of the difficulty of coping with difficulty, sort of complex needs in a child and exacerbating kind of those parenting needs. I feel like, yeah, this isn't an area I know very, very, very well, but it can kind of be associated with kind of additional needs. So like if a child has ADHD and co-occurring conduct difficulties, obviously that will have a bigger impact on the sort of struggles that parents will have in that context. Yeah, not super familiar with this, but definitely an important kind of area.
Okay. And just then maybe more of a political question as much as anything else, or a societal question. There was a couple of points there and they were talking about thresholds and women having to reach higher thresholds. Is that the fault of white middle-aged males like me?
I mean, I guess the threshold issue is because it's sort of tied in with the male presentation issue. So it's a bit of a chicken and egg, really. So if people are going to define a condition based on a particular group, whether that's, white boys or, the white middle-aged men are defining these things and having an influence on the criteria, and then the criteria they've defined are then identifying people who are like that, then it can be a self-perpetuating thing for sure. And I guess the kind of best way around that is to talk to a more diverse group of people and see what the difficulties they have. And I guess that's part of what we're trying to do with our qualitative research study, where we're talking to women and talking to parents of girls to begin to address this issue. So, I mean, I would say that is part of what's going on, but that's not specific to ADHD at all.
I suppose, yeah, it is a bigger society.
Yeah.
Lots to blame. Thanks for that. Maybe just go to Terry for the next question.
Okay, so one from Jennifer. Have there been studies into why females are less likely to be prescribed medication?
This is something that I really want to know the answer to. I don't think people have necessarily studied it. I have asked a few clinicians this question to try and understand it. And I don't know, I think people maybe on the kind of individual clinical decisions feel that the tolerance to medications or the sort of benefit people might get from medications differs for some reason, but I don't quite know why that's happening. And yeah, and it is an important kind of issue to try to rectify, to make sure that, people at least have the opportunities to take up treatment that could help them and they can make these individual decisions or their parents can support them. So I don't know if it's who's making that choice and where it's happening. Yeah, I feel like I should be writing all this down. Like, these are great research questions.
Yeah. The whole research project's coming up tonight. Well, we have it recorded, just let everybody know, so we can send Joanna the recording as well. You can get all these back again. So maybe go to Tricia for the next question.
Someone else, what does severe ADHD look like in women?
I mean, to a large degree, severe ADHD will look similar in males and females at the moment, in terms of, it will be people who meet every single one of the diagnostic criteria and who have impairments in a number of aspects of life and then develop these co-occurring difficulties as well. It's hard to say what ADHD looks like in the absence of additional symptoms. So if we had a longer checklist of like, these are also things that we consider to be ADHD, then we could kind of look at that. But I've looked and no one's really developed these additional new checklists. This is something that's sort of desperately needed, really, is to just see what other kinds of difficulties are associated. But one like really sort of disturbing statistic is that actually ADHD is very frequently associated with self-harm and suicide in women, perhaps more so than in men. And that is just unacceptable. We need to be supporting people much sooner so that it doesn't come to that kind of severe degree of mental health difficulties. But it will look like differently in each person as well. There's a huge amount of variety in how difficulties show themselves.
Again, this may be a little bit outside your current research, but is there any research that looks at the benefit of neurodiversity in society? Much like biodiversity is important in nature.
There are people talking about neurodiversity. So this conference last Friday that Ken and I were at, ADHD Foundation organized the sort of neurodiversity conference. People are beginning to talk about the kind of positive aspects of having a neurodevelopmental difference and having, maybe the ability to have a lot of ideas and take risks and do a lot of things and multitask and get things done. So there certainly kind of are social level things like that. And I'm pretty sure that there's statistics on, entrepreneurs and business owners and, individuals like that are more likely to have ADHD or other neurodevelopmental conditions. On a kind of more evolutionary level, I think it's all very speculative. I mean, a lot of evolutionary psychology theories are just very academic, and there's no way to prove or test them or anything like that. I think, yeah, it's more about kind of what's happening these days and what can we measure.
Cool. Thanks for that. Maybe just a couple more questions, and then we will need to wrap it up. Just the very last one come in there. What is the link? I'll answer this one actually. Sorry. What's the link between ADHD and money management? This is a genuine question to come in. I didn't plant this question. So just to let everybody know that next Thursday night, we have a webinar on from Stephanie Sarkis, is coming in from the States, on ADHD and money management for people with ADHD. So I'll pop that link into the chat for everybody if they're interested in that. And while I'm doing that, Terry, you'll have the next question.
Okay. So are there any links between ADHD and OCD in girls?
I mean, there are links between ADHD and OCD, just like there are with various neurodevelopmental and other mental health conditions. Again, there's co-occurrence of these conditions. So both in terms of running in families, but also in an individual may be more likely to have both than just one or the other. And again, there's some shared genetics underlying these conditions. It sort of seems like that is just the case with most brain-based neurodevelopmental, psychiatric, mental health kinds of conditions. There's some degree of overlap across these different conditions.
Okay, so just pop that link in there if anybody wants to come to our webinar next week on ADHD and money management. And we'll go to the second last question from Tricia.
From your research, have you found things that can help women manage their ADHD symptoms that do not involve medication, example, exercise and diet?
This is not something I do myself, but I certainly have seen kind of recommendations for, I mean, not just women with ADHD, but anyone with ADHD, that things like having a stable routine, sleeping well, having, doing exercise regularly, having a good diet, all the kind of things that basically your doctor will tell you to do. They all do help. They all have like a positive impact on people's mood, well-being. Sleep has an enormous impact on the ability to kind of concentrate on things. Social relationships, like meaningful, positive social relationships, are huge. So I would say all of these things are definitely good things to be doing, and maybe perhaps especially if someone has additional difficulties, whether it's ADHD or mental health difficulties or anything like that. Okay,
well, thanks for that. I think we'll wrap it up at this point because, as I say, genuinely, we could probably be going through the rest of the questions between now and midnight. We do need to draw a line at some point. So I want to say thanks to Joanne. There was huge engagement there, and that obviously shows interest. And there was a huge interest that we can see in the chat as well. So thanks to Joanne for that. And I say we run ourselves an online conference with the ADA Foundation for October. So we might have you back for that again. So thanks for that. And thanks to Terry. Thanks for Tricia for coming along tonight. Thanks for everybody that came along. There's been a huge reaction, I say, in the chat there, people saying thank you very much. And just to remind everybody, we do have the webinar next week on ADHD and money management. So thank you very much for coming along. Appreciate all your engagement. It's what makes these things worthwhile, and hopefully we'll see you again at an event very shortly.